ATLS examination in the next month. This is the reference for ATLS book. Chest X-ray are routine investigations in clinical practice and important for medical students and clinicians alike to know how to interpret them. There are many approaches to chest X-ray interpretations. It's trying to ensure key abnormalities are identified and no area is overlooked. DRS, ABCD are mnemonics. It can use a simple and approach to chest X-ray interpretations. D is the details. Okay. Begin chest X-ray interpretations. You should check the patient detail. This is the name of the patient, date of birth, identifications number, date and time of the examinations, and the previous imaging. This is useful for comparisons. D is the detail. R, this is mnemonic. RIPE. The first R is the rotation. A non-rotation film will have the spinous process. In this picture, the spinous process of the upper thoracic vertebra located centrally or crystallizely, and the equidistant for medial edge of the clavicle. Medial edge of the clavicle. This is the spinous process. This is the normal rotation. I from inspiration. Check if film is taken is full inspiration with the diaphragm at the level of the 10th to 11th ribs posteriorly or the costal cartilage anteriorly. Chest X-ray is full inspiration. P, this is picture or portrait. This is AP or PA view. And E is exposure. If adequate of exposure as determined by, you can easily visible the mid-thoracic vertebra in the intervertebral space. DR is the next is the S. S is soft tissues and bone. This is the you just see the ribs. This is the fracture ribs or the fractures of the clavicle. This fracture has the fracture clavicle. And this symmetry fractures like dislocation or lytic lesions. And soft tissue, this is looking for symmetry, swelling, or the loss of tissue plane. Subcutaneous air for looking for subcutaneous emphysema or the calcifications of the great vessel or carotid calcifications. D, R, S, the next is the A. A, this is the airway and mediastinum. This is the airway and mediastinum. This is the trachea. Begin the you use the trachea is the normal trachea is inspect for evidence of deviations. Trachea is normally the located centrally or slight deviate to the right. If trachea significant deviations, inspect for this chest X-ray is normal rotation. And if the chest X-ray normal rotation but trachea is deviate, this is the true trachea deviation. You just looking for the pushing of the trachea, so that the effusions or pneumothorax, or if the pathologies that are pulling of the trachea, such as the consolidations or atelectasis. And then you just send the main bronchus. Is the right main bronchus is generally wider, shorter, and vertical than the left main bronchus. And the next is you just find the mediastinum. The level of mediastinum you find is the aortic notch. The wide mediastinum should have a width less than 8 centimeters on the PA view. A widening mediastinum can associate with chest X-ray AP view or thoracic aortic aneurysms or rupture aortic in trauma patients or mediastinal lymphadenopathy. DRSA, and the next is the B. B is the breathing. Breathing, we inspect the lung for abnormality is the lung marking, atelectasis consolidation, and the pleura. Pleura are not usually visible, is normal. If you can visible the pleura, it just is the pleural thickening. And then inspect the border of the each lung to ensure this is a normal lung marking. If absence of lung marking and you see invisible pleura, it is suggested pneumothorax. E, R, S, A, B, and C. C is the circulation. Circulation, you in a healthy patient, this is the heart size is the occupy normally no more than 80% of the thoracic width. The screw only approach in chest X-ray PA view. You just approach the heart side, chest, aortic strip. D, R, S, A, B, C, and the next is the D. D is the diaphragm. You just see the right diaphragm is usually higher than the left diaphragm, about by 1 to 3 centimeters. And you just see the claustrophrenic angle for see the branch claustrophrenic angle or shaft claustrophrenic angle for see the pleural effusions or pneumothorax. And then the gastric bubble in the chest X-ray PA view, and see the subdiaphragmatic air for see the new hollow viscous organ injuries or rupture hollow viscous in the abdomen. And the last is the E, the extra. You just see the tip of endotracheal tubes, the C line or catheter EKG electrodes in the chest X-ray. Finally, before completing your assessment of chest X-ray, make sure you look for the hidden area. The hidden area is include the lung apical or retrocardiac regions and behind the diaphragm. Okay. This is the, I just give you the whole message. This is the mnemonic of chest X-ray, DRSABCD. If you prepare the examinations in ATLS, this is the appendix of the ATLS book. Thank you for your listening. What about the questions? Widening mediastinum ที่เขียนในของ Light in the Fast Lens ก็คือ8เซนค่ะอาจารย์วัดจาก aortic knob จะต้องเป็นท่า PA ค่ะ AP ไม่ได้มีเขียนไว้ชัดเจนค่ะตรงนี้ aortic knob แล้วก็จะเป็นไล่ลงมามันก็จะเป็นแบบ main bronchus ค่ะแล้วก็ left atrium ทีนี้เวลาวัดก็คือวัดตรง aortic knob
differentiate อะไรบ้าง
คือ widening mediastinum มันมี differentiate ค่อนข้างเยอะค่ะอาจารย์ก็คือแบบ
แล้วถ้าเป็นเคสทอม่านี่เราก็เขียนไปแล้วเนาะเขียนอะไรบ้างถ้าเป็นทอม่า
แล้วก็ถ้าเป็นของเป็น disease พวกนี้ก็จะเป็นเรื่องของ mediastinal lymphadenopathy แล้วก็ดูเรื่องของถ้าเป็นแบบพวกไทโมมาพวกแมสอะไรอย่างเงี้ยค่ะ
ไทโมมาเขียนในเด็กเนาะ
ใช่ค่ะสอน
differentiate พวกแมสได้หมดเลยเนาะแมสที่ anterior middle กับ posterior mediastinal เนาะเฮอร์เนียก็ได้นะ diaphragmatic hernia แล้วก็อีกอันหนึ่งที่เป็นแบบ technical factor อ่ะพวกเวลาเราทำบางทีคนไข้อาจจะไม่มีอะไรนะแต่ว่าบางทีเทคนิคของการเอ็กซเรย์อ่ะอย่างเช่นการโรเตทคนไข้ใช่ไหมถ้ามันไม่ใช่ true PA อ่ะแบบบิดเป็น oblique หน่อยนึงหรือคนไข้แบบ poor inspire หรือว่านอนท่าซุพายหรือคนไข้ที่แบบหลังก็เป็น lordotic position อ่ะพวกเนี้ยก็ทำให้ดูแบบเป็นเหมือนกับ technical error ได้เนาะจากเอ็กซเรย์ เจอบ่อยอยู่เนาะไอ้พวกโรเตทอะไอ้พวกแบบเป็นออฟลีกหน่อยอะดูฟิล์มเช็คก็จะพอดูข้างนอกประกอบได้อยู่